most of you know that I see patients about 2 days a week, and 5 days a week I do research, and that's mostly literature, as well as in my practice I have 6 or 7 research projects going on at one time. And in reading the literature, the information is changing so rapidly. I mean, how many people here have a copy of the new American Association of Clinical Endocrinologists October-September publication on growth hormone use? That many. One. It has some interesting changes in the use of growth hormone. They now finally talk about traumatic brain injury. Those of you who were in the workshop yesterday where I was speaking on growth hormone and traumatic brain injury and hormone deficiency syndrome got a piece of the new updates where they also acknowledge the deficiency and traumatic brain injury, also the relationship between growth hormone deficiency and increased risk for cardiovascular disease. Things that we're going to talk about is regulatory aspects, because the perception and the means by which we determine a deficiency state or an insufficiency state is changing. We have a little bit more leeway in how we interpret it. Also go over structure, signaling, interesting aspect about tumor suppressor and the story about growth hormone's risk for cancers. Binding protein 3 and tumor suppression, growth hormone versus IGF-1, and some of the more common growth hormone research projects in application. Well, as we know, growth hormone has a number of things that stimulate it. Bodybuilders use amino acids, and we've had amino acids of a variety type that help to increase the production of growth hormone. Obviously, growth hormone releasing hormone, ghrelin, sleep because of melatonin going up. In fact, if you just supplement with a very small dose, 0.5 milligrams or 1 milligram, instead of taking the 3 milligrams to sleep, even though you're sleeping very well, will help augment the production of growth hormone. Increased aerobic activity is very positive. Low blood sugar, dietary proteins, the arginine, ornithine, pyroglutamines, the alpha-ketoglutarate also. Estradiol centrally has a upregulating effect on the production of growth hormone, and peripherally at the cell wall receptor of growth hormone has a decreasing effect, a negative effect, a partial. Arginine is positive because it suppresses superoptic nucleus production of somatostatin. So if you can decrease somatostatin, your body will have a higher threshold of production of growth hormone before it's shut down by somatostatin. Things that inhibit or suppress the growth hormone production is obviously somatostatin, which goes by another name in the literature, which is SRIF, somatotropic releasing inhibiting factor. Circulating levels of growth hormone and IGF-1 are also suppressing, self-regulating directly, not only somatostatin, but the level of growth hormone and IGF-1. Growth hormone centrally in the brain, and IGF-1 initially peripherally, since it's produced by the liver, circulating back through the cerebral circulation, hypothalamic circulation, leads to stimulation of somatostatin, as well as a decrease in cell wall production of growth hormone releasing hormone receptors, as well as the growth hormone releasing hormone itself. Glucocorticoids, dietary carbohydrates, carbohydrate-rich diets. Obesity is a very important aspect. If you have a patient who is obese, it's a given that they have a deficiency of growth hormone. Tamoxifen, the medication tamoxifen, centrally suppresses the production of growth hormone. And this is the article that talks about it. There were those articles that came out about protecting from breast cancer. Instead of using indole-3-carbinol or diindomethane, it's using tamoxifen to block the receptors. At the same time, what you're doing is you're downregulating the production of growth hormone. And this is the structure of growth hormone. It has 2 receptor sites, the glycine-arginine receptor sites. Both of these have to attach to their receptors on the cell wall in order to have a maximum response from growth hormone. There are people who have growth hormone insensitivity, which is due to an abnormality, a mosaic abnormality, genetic predisposition for one of those receptors. In both receptors, called Laronne syndrome, what happens is you have no growth hormone receptors. So you draw the blood of someone who has all the symptoms of growth hormone deficiency, and you get a blood level that's sky high. You won't pick up IGF-1. And the way that all hormones work is they affix or attach to their cell wall receptor, and they activate a signal transducer and activation of transcription that goes into the cell, the JAK, which is just another kinase, or Janus alpha kinase, and stimulates the production of a component which goes into the nucleus that specifically turns on areas of DNA that, in this case, growth hormone would stimulate 3 groups, one being IGF-1 and 2, the other being binding protein 1 through 6, and lastly, acid labile subunit. How many people know about acid labile subunit? It's the forgotten carrier. We'll talk about it shortly. And this is just the verbiage that I just said. Estrogen, the article about estrogen, inhibits growth hormone signaling by suppressing GH-induced JAK2 that I just showed you. It suppresses some of the phosphorylation that actually intracellularly in the cytosol activates the process to go into the nucleus. So it seems that oral estrogen administration reduces IGF-1 by increasing this process. So topical is better. And we might be talking a very little bit. So it's not a magnitude to cause us to change our treatments. This one will pass. This one will pass. Now, the issue relative to growth hormones association with cancer, and you have to understand that in order for this, what I'm going to present, to work, you have to have exceedingly high levels of growth hormone. And in talking with the governor of California and a couple of the actors, you know, they don't have cancer, and they were using god-awful levels of growth hormone back in when it was from monkey brain and cadavers extracted, and then subsequent to the '86 production of Eli Lilly's Humatrope, and the other one was, what was it, one of the other companies, don't remember the other company. They were using, you know, 10 units a day, 12 units a day. AIDS patients, the little bottles of Serona is how many milligrams per bottle? 6. 6 times 3 is 18 units a day, and that's why each box had 7 vials, because they were to take, for wasting syndrome associated with HIV, we're supposed to take 18 units a day.